Epilepsy. So epilepsy is a common type of seizure disorder. Now, this disorder relates to hyperexcitability of neurons in the brain, which continually trigger electrical signals or impulses that are then sent out to our muscles and other parts of our body. So that's where you start to see your patients in that convulsive state. So let's talk about epilepsy. So again, it's just a disorder where the nerve cell activity is disrupted, and there's tons of, I say, misfiring or just unnecessarily firing or sending signals causing seizures. Okay, so we're sending all of those unwanted electrical signals to our muscles. Now, all of those signals that are repeatedly being sent are causing that hyperexcitability of our central nervous system. So that's when you start to see your patients maybe fall on the floor and you start to see their body seize and convulse. And they have no control over their bodies at this point in time. Okay, so they may have contractions of their arms, their legs, maybe their facial muscles, so just various areas. And again, they have no control over this. So just because your patient has a seizure does not mean they have epilepsy as far as being diagnosed or that it may continue. So many times people can have a seizure that's brought on by something other than just a disorder, something else going on in the brain. So you can have a seizure if you have extremely high fevers, if you have a patient who's been in a motor vehicle accident and had some type of head trauma or even a fall. Extremely low blood sugars will also cause seizure activities. Remember, we need that glucose in the brain to function correctly. Alcohol withdrawal, that can also cause seizure activity. So a lot of times you'll see those people who are going through alcohol withdrawal, they're going to receive some type of anti-epileptic medication while they're going through that withdrawal process. Brain tumors, infection, of course, meningitis, and even poisoning can cause seizures. So when your patient has a seizure, you may see them lose consciousness, okay? And so with that, you may see some vision changes. They may not respond to your voice, okay? They may not be able to hear or to feel you touching them if you're trying to arouse them. And then patients have also said they have changes in taste and smell. So there's a couple of different types of seizures, and those are partial and generalized. Now there are subtypes of each one, and if you look on page 170 on box 9.5, we can look at the different types of seizure activity. So I will tell you up front that you need to know the types of seizures as far as it relates to partial versus generalized and what the subtypes are. You also need to know which type of seizure loses consciousness and which one does not. And if they do lose consciousness, how long is that time frame of unconsciousness? Okay, now your patient can show or exhibit various seizure activity and symptoms of that seizure based on which area of the brain is affected by this hyperexcitability. Okay, so there's various different symptoms, and we'll talk about those. So let's look at the seizure classifications. So we have partial seizures, and then we have generalized seizures. So the first one you'll see in partial is going to be your simple seizures, and there's no loss of consciousness with this particular seizure. They're quick and sometimes not even noticeable. Your patient or your whoever is experiencing this partial seizure may just appear to be daydreaming. They kind of have that fixed gaze upon them. Now, typically, this type of seizure consists of slight changes in our senses and maybe, just like we snap out of it and just try to gather our bearings and our whereabouts. There may be some twitching of the toes, feet, fingers, and arms, lasting less than 60 seconds, so about 20 to 60 seconds. And I will tell you, you need to know the length of time on the seizures and how long they last, okay? Because I know they're going to test you on that. So the difference in a partial seizure and a complex seizure, which is the next one, simply involves the loss of consciousness. So in a complex seizure, we of course see that fixed gaze, and they're not responding to any type of stimulation. And so with a complex seizure, you're going to see some repetitive motions. It might be pedaling of their feet, or moving of the head in a specific way, either yes or no, or something of that nature. Or they could just be sitting there with an emotionless blank stare. Okay, so the key to determining the difference is, again, that number one, loss of consciousness and the repetitive motions. So that's how you can differentiate the two. Now, the complex seizures will last about 45 seconds to 90 seconds. So it lasts a little bit longer than the simple seizure. So just know the difference between those. Now, partial with secondary generalization, I don't really think they're going to test you on that, but you need to know just the difference between simple and complex. So a partial with secondary generalization, it just starts as a partial seizure, and then they retain consciousness, and then they progress to a loss of consciousness. So just know the difference in the simple and the complex. So generalized, let's talk about those. So we have absent seizures, and those are sometimes called petit mal seizures. So we have grand mal and we have petit mal. So we'll talk about both of those. Now with absent seizures, they do have a loss of consciousness. It's typically less than about 30 seconds. And absent seizures actually affect both sides of the brain at the same time. Most of the time this is common in children. And then absent seizures rarely involve those motor movements. So you're not going to see those hands moving or those feet pedaling or anything like that. Okay. Now, on the opposite end of the spectrum, you have the grand mal seizures. These are your tonic-clonic seizures. So with the tonic-clonic seizures or the grand mal seizures, typically your patient will have some type of aura, kind of like when people suffer from migraines and they have that aura and they know that it's coming. And they may be even be able to say to you, I'm going to have a seizure. Okay, so it's not uncommon that they can let you know because they have that aura that precedes that seizure. So when your patient or anybody who suffers from a grand mal seizure, you're going to see those extreme bodily movements, just that whole convulsing of the body. Now, in the beginning, they're very rigid, and then they begin to have those compulsive movements or convulsive movements, and then they just lose their whole posture. Okay. Now, once they're over, we call this like a post-ictal state, and this is when they're sort of coming out of this whole seizure activity, and they may be confused and just kind of gathering their whereabouts. Now, on average, this tonic-clonic or a grand mal seizure lasts about 90 seconds. Now, another one we have is an atonic myoclonic seizure. Now, this one is a little different because what happens is basically they experience a myoclonic seizure followed by atonic. So, excuse me, with the myoclonic, you're going to have those jerky movements, and then you have atonia. So we just know that that's an absence of tone, okay? So another thing about the atonic myoclonic is this is sometimes called drop attacks because your patient may be, they might even be just standing and then suddenly they fall and then they're going to experience that seizure activity. So status epilepticus is a single seizure that lasts 15 to 30 minutes, or it can be a series of seizures in which your patient has a seizure, never regains consciousness, has another seizure, does not regain consciousness. So just in between those continual recurrent seizures, they're not regaining consciousness. So it can vary. It can be a myoclonic seizure. It could be a convulsive, just a varying type of activity. But now, if you're a status epilepticus, sometimes that's hard for me to say, this can actually be life-threatening and it can even cause death. Okay, so if you think about it, these seizures are lasting up to 30 minutes, 15 to 30 minutes of continuous seizure activity or recurrent seizure activity with no consciousness regained. So you have to think about their number one, oxygenation, and then how that can cause permanent brain damage and ultimately their death. Now, febrile seizures is just what it says. It is caused by typically high fevers. Mostly in children is where you're going to see the febrile seizures. And this is typically between 15 and 30 seconds as far as a time frame on how long that lasts. So those are your various seizure classifications. So the most important part is knowing the difference between which one loses consciousness and which ones do not, and some of the motions that set it aside or makes it different from the others, like your pedaling motions or those continuous motions. And then the duration, okay, so know those time frames. So we talked about our seizure classification. So now let's talk about how we're going to treat that particular diagnosis. So normally we have traditional anti-epileptic drugs. I simply just call them AEDs because it's easier. So with our traditional AEDs, those are going to be your phentoians, your carbamazepine, your ethosuximide, there's valproic acid, and phenobarbital. So phentoians and the carbamazepine, they both work by increasing that seizure threshold, and they just basically bind to the sodium receptors on the nerves to make them less active. Okay, so think back to how we talked about the seizure threshold with some of the other medications earlier on, and that it lowered that seizure threshold. That was one of the side effects of particular medication. I don't really remember what it was, but when we increase the seizure threshold, then it takes a lot more excitation in order to create that, or a stronger excitation to create those seizures. Okay, so phentoians and carbamazepine slows the firing at the neurons. Okay, that's your carbamazepine. Now, they both work by altering those sodium levels. Now, when we move down to ethosuximide, they increase the seizure threshold by altering calcium levels. Okay, now, when we talk about the AEDs and you're studying them, make sure that you know the difference in which medications alter what. So know which one alters your sodium and know which medication alters your calcium levels in the brain in order to increase that seizure threshold. Now, ethosuximide is most effective for absent seizures. Okay, so one thing that is also different with ethosuximide is that we can actually give this to mothers who are pregnant, okay, because it is the least likely to cause birth defects. Now, the others, we typically try to avoid them in pregnancy because it has shown to cause some type of birth defects. So we want to avoid those. So your ethosuximide is going to be mostly prescribed to patients who have those absent seizures or those petit mal seizures, okay? So continuing with those anti-epileptic drugs or our traditional AEDs, let's talk about phenobarbital. So phenobarbital is also barbiturate. Of course, anytime you hear barbiturate, we need to think about CNS depression, okay? So phenobarbital works by raising that seizure threshold, and it works differently than the other two medications, the ethosuximide and the carbamazepine and phentoins. Those three work on calcium and sodium channels, whereas phenobarbital actually works in the GABA neurotransmitter receptors. Remember, we talked about GABA earlier on, and those GABA receptors, or that GABA neurotransmitter, is an inhibitory neurotransmitter. So it's going to kind of neutralize that transmission of all of those signals, okay? Now, I've already told you it causes CNS depression, so phenobarbital can cause some, of course, I guess, sleepiness, drowsiness, those types of CNS depressive symptoms. Now, phenobarbital has the longest duration of action, okay? It is used for many types of seizures. The only one that it is not used for is absence seizures, or those petit mal seizures, okay? Now, phenobarbital can also be used short-term for insomnia and anxiety. Again, it is a barbiturate, and they can use it for that. Now, I do recall when I was working in the NICU, they used phenobarbital on neonates who had cholestatic jaundice. And for whatever reason, I'm not sure what the action was or how it worked, but it always worked for that jaundice. So there's other uses for it, but in seizures, just remember that this one works in that different way as the others do, because it works in the neurotransmitter area, those neurotransmitter receptors. And it is not used for absence seizures, okay? And then we have, last but not least, valproic acid. So it also works by raising the seizure threshold, and it works on those GABA receptors, okay? So again, it works the same way phenobarbital does. It's decreasing those neural transmissions, therefore increasing the threshold, so it takes a stronger amount of excitation in order to cause a seizure. Okay, so valproic acid is also used in mental health to treat sometimes manic episodes and bipolar disorder. So there are other uses for many medications that we come into contact with, but just know that these two are particular in the in the way that they work at the GABA receptors. Okay, so they're different from the other traditional drugs, but just know that they work on the GABA receptors. The most common side effects with our anti-epileptic drugs are pretty straightforward. Phentoin is gum hyperplasia, which is simply just an overgrowth of that gum tissue. So we want to make sure that we're educating our patients about good oral hygiene. It can have some abdominal discomfort, and this particular medication, phentoins, out of all of the AEDs, it does not cause drowsiness. All of these others do. So it could have some advantages over some of the others just because it does not cause that drowsiness. Now, carbamazepine is straightforward. This is just your constipation, nausea, vomiting, and ataxia, which we talked about earlier in the chapter, is just those unsteady walking, that unsteady gait in our patients. This particular medication can cause some sun sensitivity, so we want to be mindful of making them aware of limiting time in their sun in the sun and wearing sunscreen when they are in the sun. Rash and muscle weakness. So Lacosamide is probably one of the least. Heartburn, nausea, vomiting, dizziness, drowsiness, and fatigue. Now, phenobarbital and primidone, you have to think about that because phenobarbital is a barbiturate, so you're going to see that CNS depressive signs. So decreased alert, maybe decreased heart rate, blood pressure, drowsiness. Again, you may see that ataxia with that hypotension, some blurred vision, dizziness, and those mental status changes. Okay, so that's all in that central nervous system. And that goes back to phenobarbital being a barbiturate. Now, valproic acid is drowsiness, muscle weakness, nausea, diarrhea, menstrual irregularities, anorexia, double vision, blurred vision. Okay, so valproic acid seems to have quite a few most common side effects. So just know what those are. Think about the medications, what's different about each of them. So phentoin is your gum hyperplasia. Carbamazepine is ataxia and some sensitivities. Phenobarbital is going to be your CNS depression. Okay, look back at that CNS depression if you don't remember what those were. And as far as valproic acid, there's a lot of them. Just find something that works for you. I'm going to say double vision and blurred vision and those menstrual irregularities because they're different from all of the others. The adverse reactions of our AEDs are widespread. So phentoin is a known teratogen, so we avoid it completely in pregnancy for fear of birth defects. So phentoin and carbamazepine both affect bone marrow. So they're both going to decrease our white blood cells and our platelets. So we look at the increased risk of infection, and we also monitor increased risks of bleeding in our patients. Now, phentoin can cause bradycardia and some skin issues. So if you were to see on a test that your patient has described a rash on their body once they've started taking this phentoin, then they need to report that immediately to their physician because that can be signs of an issue with their skin that leads to a more severe case of Stevens-Johnson syndrome. Now, in Stevens-Johnson's, what happens is they may start with a small rash and then it starts to spread. This can actually even be inside the mucous membranes, your mouth, and things like that. And so basically that rash begins to turn into blisters and it's very painful. So phentoin, again, known teratogen, and Stevens-Johnson syndrome. Carbamazepine, as I said, can cause anemia because it does affect the bone marrow. Again, it decreases white blood cells and platelets. So again, we're looking at that patient's increased risk of infection and an increased risk of bleeding. Now, carbamazepine can cause arrhythmias, tachycardia specifically, AFib, and severe hypertension. Now, phenobarbital, again, is that barbiturate. So we're going to see respiratory depression, and this medication should be avoided in patients with COPD. Why? Because it creates respiratory depression as an adverse reaction. And if our patients already have some type of compromised system, we don't want to further that depression in our COPD patients, okay? Now, phenobarbital, remember, is a barbiturate, so it is a controlled substance. So with that being controlled, then there is significant tendencies for dependency. All right, so phenobarbital can also cause bone marrow depression. It can cause cognitive impairments. Remember, we're going to see some of that sedation from the phenobarb because it is a barbiturate. Now, this one in particular can cause liver impairment, especially in long-term use. So think about children who might be receiving phenobarbital and how small that window is for them as far as liver impairment. Children less than 2 years run the risk of liver toxicity, okay, and bradycardia, even into coma. Remember, phenobarb is going to have that respiratory depression, so we have to be very careful when we give this medication. Now, valproic acid has been known to cause amnesia, arrhythmias, hearing loss, and GI bleeding. Now, these are your adverse reactions, so if your patient is suffering from any of those when taking any of these medications, they need to report them immediately so that that medication can be changed. Drug interactions for our traditional AEDs are widespread. So I would always encourage my patient to consult with a physician or pharmacist if they are in fact taking any of the following medications, especially if they're taking any of the following with our AEDs. So aspirin, of course, acetaminophen, and then warfarin. So any of those can create that prolonged bleeding. Now, when it comes to warfarin, you guys need to know which medication increases warfarin and which medication decreases warfarin and the effects of it. So carbamazepine reduces the effects of warfarin. Okay, so valproic acid increases warfarin. So you're gonna think about those dose changes. Okay, either increases or decreases depending on which medication they might be taking. Now, AEDs also interfere with oral contraceptives. Okay, it reduces the effectiveness of oral contraceptives. And basically, it boils down to an isosome in the AEDs that accelerate the conversion of estrogen and progesterone, which are our oral contraceptives. And so therefore it decreases that efficacy of them. So if you have someone who is of childbearing age or anything like that, we need to make sure that they're either using a different form or a backup. Now, proton pump inhibitors and drugs for diabetes. So this boils down to the metabolism of those medications. So when you take a proton pump inhibitor, remember they're turning off that pump to decrease the gastric secretions in order to lower that acidic environment. So by doing that, if you're taking both medications, you're turning off the gastric pump. So there's not enough of an acidic environment maybe to melt those or to metabolize that medication. So it's just decreasing the metabolism of those. So those are some of the most common interactions with medications that patients take. So again, there are many, many drugs that AEDs interact with. So again, encourage your patient to consult with a pharmacist before, taking anything that they're unsure of with their AEDs. Teaching and nursing responsibilities when it comes to AEDs vary. So let's talk about the different medications and what those are. So with phentoin, we need to understand that there are different forms of phentoin and that they are not interchangeable. Drug concentrations vary depending on the type of prescribed. So warn your patients about gum hyperplasia and making sure that they have good oral hygiene if they're taking phentoin. Now, phentoin has mixed interactions on warfarin, so they're mixed as far as does it increase or decrease the efficacy or the action of that. So really, we just need to educate them on the monitoring of their anticoagulants and those lab results if they are in fact taking both of these at the same time. Now, this particular medication can be very irritating to the tissue. So we try not to give it IM, okay? Remember that. And phentoin is known to cause birth defects, so we do not use it during pregnancy. Teach them to take their pulse. Remember we talked about bradycardia and those other arrhythmias. So with phentoin, think about all of those. Try to give it in any other method except IM because it can cause severe irritation in the area where you give it. Now, carbamazepine, when we talk about this medication and our teaching points, we do not give this one in pregnancy either because it can cause birth defects. Again, teaching them to take that pulse daily because this too can also cause tachycardia, atrial fibrillation, and those other arrhythmias. Ataxia, we want them to, think about those uncontrolled movements and that unsteady movement, I guess I should say. So being mindful of risks of falls, okay, or their increased risk of falls. And again, think about carbamazepine. Remember, carbamazepine actually reduces the effect of warfarin. So you're going to see their doses increased if they're taking warfarin. They're going to increase the warfarin dose, not the carbamazepine. Now with ethosuximide, remember this is the one that we can use in pregnancy because it has the lowest risk of birth defects. So we can use that during pregnancy. So that's one of the advantages to that medication. As far as GI side effects, just ask them to take it with meals or a snack to decrease those problems. Now, phenobarbital, again, this is not given in pregnancy. It can cause birth defects. And remember, phenobarbital is our barbiturate. So again, teaching them about the CNS depression, that respiratory depression, and cognitive impairment, okay? And this can be profound, okay? So remember those adverse effects. So be mindful of telling them, what the CNS depression looks like, that decreased heart rate, decreased blood pressure, drowsiness, those types of things. And again, with phenobarbital, since it is a barbiturate, you want to make sure that warn their families and teach them about the increased risk for falls and how to prevent some of those. Remember maybe those non-skid socks or removing the rugs, and be cautious of pets. Now, valproic acid increases the action of warfarin. So you're going to see the dosage of warfarin decreased in this case. Now, valproic acid, especially with young children, remember we talked a little bit earlier about the toxicity of it with the liver. So we want our patients, especially the parents of children, to be monitoring that whites of the eyes and the skin for that yellow in color, that jaundice. Any darkening of the urine, we want that reported also. So notify them immediately. And then again, we do not use valproic acid for or anytime during pregnancy. So those are your teaching points and your responsibilities as the nurse caring for patients who are taking these particular medications. Okay, so when we're talking about teaching, make sure that you remember which ones you can take during pregnancy and which one you cannot, and what their effects are as far as warfarin. Does it increase or decrease? And then once you decide that, how are they going to change the dose of the warfarin that your patient is taking? Some newer AEDs that we're going to talk about, some have been approved for monotherapy, meaning that they can be used alone to treat patients who suffer from epilepsy, or they are used as an adjunctive therapy with traditional AEDs. So they might not be as effective, or they may increase the effects of the traditional AEDs. So there are 4 that are actually approved for monotherapy, and those are the 4 that we're going to talk about most in this chapter. So oxcarbazepine is a derivative of carbamazepine. You can see that carbazepine is very similar to carbamazepine. Anyway, they both work to block those sodium channels. However, oxcarbazepine has fewer side effects than the carbamazepine. That's a mouthful. Sorry. So oxcarbazepine, one of the most common side effects is visual. It affects our vision. So some blurred vision, double vision. Your patients may have some drowsiness, dizziness, headache, things of that nature, but that comes into play with the adverse effects, the hyponatremia. So because it does block the sodium channels, we may not have as much, circulating sodium in the system. So that's going to be your adverse effects. So amnesia is also another one. Now, anytime we talk about hyponatremia, we need to consider several things. Of course, muscles and our cardiac status. And I don't know if you guys really remember, but some of the symptoms of decreased sodium is going to be muscle weakness, headache, and a decreased deep tendon reflex. So if we were to check your reflexes, tap on the knee, you're going to see a decreased response in that if they're suffering from those adverse effects with that hyponatremia. Now, another thing we have to think about when we talk about hyponatremia and the lack of sodium is the use of diuretics. Okay, are we using a potassium or sodium wasting diuretic or a sodium sparing diuretic? Okay, so just be cautious with that. The rarest side effect of oxcarbazepine is bone marrow suppression. So with bone marrow suppression, you guys, we've talked about this several times, you see that decrease in white blood cells, therefore you have an increase of infection risk. So just remember those. Some of the drug interactions for oxcarbazepine is the same exact thing as carbamazepine. Now, there are a few added to this particular drug, so separate those that are different so that you can better pick them out on testing, let's say it that way. So all of the other drugs that carbamazepine interacts with, this one does also. However, this one has also listed antipsychotics and HIV drugs. So just a few more. Remember we talked about there is a plethora of drugs that our AEDs interact with. So we always have to weigh the risk and the benefits when we give any AED at all whatsoever. Okay, so sometimes you just have to roll a dice and take a chance that your patient won't suffer from any of those adverse reactions. So again, just weighing those risks and benefits, because from aspirin to acetaminophen and the huge list of drugs that it interacts with, your patient is most likely going to be taking a couple of those in addition to their AEDs. So just be mindful of oxcarbazepine. Some of the teachings, of course, is going to be lab work. Obviously, if hyponatremia is one of the adverse effects, they're going to start watching those sodium levels. Okay, so we want to report that if it's less than 135. Remember, that's 135 to 145. So anything less than that, we're going to report. Any type of extreme muscle weakness, continued infections, anything like that, we're going to report that because those are adverse effects of this medication. This medication also affects oral contraceptives just the same as our traditional AEDs. So again, you want to educate your patients on the use of a backup method or maybe even changing the route that they deliver that altogether. If they're taking oral, maybe they can wear a patch if they have to take an AED. So those are your teaching points with oxcarbazepine. That one's pretty straightforward. We also know that folic acid is important because it helps maintain those red blood cells. Okay, so it's important that if you have a patient taking this, then they're going to have some lab work because we want to check that folic acid level to make sure that they don't become anemic. Okay, so the adverse effects are those life-threatening rashes, that Stevens-Johnson syndrome. Remember, we talked about the rash and that they need to report that immediately because then it becomes those blisters that spread. Okay. This is typically seen in children, the Stevens-Johnson syndrome. But there's also another one, it's called toxic epidermal necrolysis. And it is, again, typically seen in children. But 10 is what they call it. It's a severe skin reaction. And so with the 10, what you're going to see is a flu-like symptom. So if you were taking a test and we told you this child had flu-like symptoms taking Lamotrigine, then you should trigger to think Stevens-Johnson syndrome or that 10s, that toxic necrolysis. And basically what happens is the skin begins to just slough off and becomes extremely painful, leaving those raw areas on their skin. So always make sure you have them report any type of rash at all whatsoever when beginning this medication. Now, again, your drug interactions are almost the exact same as the ones we've talked about previously. So the difference in this medication, which is an outlier, and the other medications is that this one actually interferes with TB. Okay, remember everybody probably had a TB test. So your Lamotrigine is one that's going to interfere with your TB testing. Okay, so just be sure that when you're picking those outliers to remember for testing that you look for those things that are different. So every single one of those AEDs, whether new or old, interact with all of those other things except for your antipsychotics, your HIVs, and your TBs. So know which one of those are different, and that'll make it easier for you. And then again, your diabetes medications. So that's Lamotrigine. Now, again, this one's blocking your sodium channel, so you want to look for those hyponatremia, those signs and symptoms of hyponatremia. Okay, educate them on folic acid supplements if they are lacking. Now, one particular thing I will tell you about this is if you have someone who is African American, then they're actually going to probably have a lower dosage of this medication because they tend to have a lower clearance rate. They're not clearing this medication appropriately. Don't know the rhyme or reason for it, but they often do need a lower dosage to prevent that overdose of symptoms. Continuing with Lamotrigine, I just wanted to touch base with you because your book talks about your planning and implementation parts and your responsibilities. This particular medication comes with a starter kit. So the starter kit is based on whether this is a monotherapy or if it's given as an adjunctive therapy with an older AED. So depending on whatever monotherapy or adjunctive therapy your patient is taking will determine which starter kit is prescribed. So just know that there are starter kits and we need to use the appropriate one. Now, we as the nurse and them as the patient need to be extremely mindful of assessing that skin daily and charting that. And again, I can't stress the importance of remember assessing patients of other races because they do have a lower clearance rate. And remember, that's going to be your creatinine level to tell you how well they're excreting that medication. So these patients may have to come in for a creatinine level every now and then. So when we talk about this medication, one of the side effects was dry mouth. So sucking on hard candy or even chewing gum can sometimes facilitate more saliva. So also drinking more water, of course, but those are two of the big suggestions that we give to patients who are suffering from severe dry mouth. So if you see that on a test or on NCLEX, then you'll know that's going to be your answer. So that's Lamotrigine. It's pretty straightforward because you've already discussed most of the side effects and adverse effects of the AEDs previously. These go by pretty quickly because they're all just about the same. So any questions on any of those, just let me know and we'll talk about them. Lacosamide is another Topiramate is the next one we'll talk about, and Topiramate works in 3 different ways. Topiramate basically prevents the spread of that excitability in those neurons. So it doesn't raise the seizure threshold, it just prevents that spread of the excitability. So the first way it works is at the sodium channels. It's going to block those sodium channels to stabilize that those neurons and that excessive firing. Secondly, it enhances the inhibitory neurotransmitter GABA. Remember, we talked about GABA being kind of a regulator. Okay, so we're enhancing that. So by enhancing the GABA receptors and the GABA neurotransmitter, then we can decrease that epinephrine, the norepinephrine, and the actions of acetylcholine. So we're blocking those excitatory receptors when we enhance those GABA neurotransmitters. Now, this particular medication is approved for a monotherapy, so it can be used alone, and it's typically used for partial seizures, tonic-clonics, and then the Lennox-Gastaut syndrome that we talked about earlier. This one has also been used to treat migraines, okay? So we'll just know what it does for a seizure activity. I'm not going to test you on migraines, but it has been used for that purpose. Some common side effects with topiramate is that abdominal pain, some nausea, dizziness, drowsiness, fatigue, changes in taste. That's different from some of the other AEDs, and your anorexia and your paresthesia. Paresthesia is simply just a sensation of numbness, of tingling, as if you're walking on pins and needles. Okay, so that's what paresthesia is. Now, your adverse side effects with topiramate is some memory impairment and electrolyte imbalances. Now, specifically phosphorus and calcium. So, why is that important? Well, phosphorus, of course, and calcium helps in the formation of bones. Okay, calcium is important because that helps our muscles move. Now, phosphorus also helps with how the body uses carbohydrates, and it also helps our body make protein. So, extremely important imbalances there. At higher doses can cause elevated ammonia levels, which then leads to changes in consciousness, or I guess I should probably lean toward more toward confusion. High ammonia levels can cause severe confusion in patients. High ammonia levels also can lead to encephalopathy or brain damage ultimately, and then death. Okay, so it's extremely important that we're checking those ammonia levels. So some of the signs of an increased ammonia level is going to be unexplained vomiting, extreme lethargy. You know, they're very lethargic. Temperatures that are extremely cold. So, knowing all of that, we want to monitor some ammonia levels. We want to monitor our temperatures and our mental status. So, are they alert oriented? Do they know where they are? Are they saying things that are just completely off the wall, unexplainable? Because ammonia levels will do that. So, ammonia levels usually 10 to 8, I think it's micrograms per deciliter. But I'm not going to test you necessarily on the level specifically. Sorry, but you do need to know that we're going to have some labs to monitor those ammonia levels. Now, lastly, topiramate is a known teratogen, so we are going to completely avoid it during pregnancy unless we just cannot control that seizure activity in any other way. Okay, now just as the same as all other AEDs, it can adversely cause some suicidal ideation and depression. Okay, so the biggest thing with topiramate is those increased ammonia levels and those electrolyte imbalances. So remember those. Drug interactions with topiramate are almost exactly the same as all of the other AEDs. This one is a little different. It does interfere with those cardiac drugs, so making sure that we're checking pulses, checking blood pressure. All of the rest are pretty much the same. Diuretics, diabetes, oral contraceptives. So the symptoms of multiple sclerosis can vary because it depends on what part of the brain and spinal cord that myelin has hardened in. So it can vary. Some common early symptoms of multiple sclerosis, if you look on page 179, I think it's box, it looks like 9.8, we can talk about some of those common early symptoms. So fatigue, double vision, blurry vision, muscle weakness, numbness of your arms and legs, difficulties walking, urinary tract infections, bowel and bladder dysfunction, depression, and difficulty concentrating. So our spinal cord innervates pretty much every part of our body. So that's why we can have all of those symptoms. Maybe not all of them together, but your patient's probably going to experience several of them when you start assessing them. MS is a progressive disease. They tend to have worsening symptoms as it progresses and fewer periods of remission. Okay, so multiple sclerosis cannot be reversed. Okay, and there is no cure. We can medicate it just like Parkinson's or anything else to alleviate some of the symptoms and slow the progression, but we cannot reverse any of that. Now, as we start to talk about some of the things that we use for multiple sclerosis, I want you to pay especially close attention to middle of the page on 179 when we're talking about multiple sclerosis. It talks about management of MS and that every single first dose of these drug regimens are started with a specialist. So if you see on a test anything about MS in the beginning of treatment, then you're going to know that your patient is in a clinic somewhere with a specialist before they ever start this regimen. As this disease progresses, you'll start to see these patients decline in such a way that they end up in assisted living or long-term care facilities because they can no longer take care of themselves, and it's very trying and tiresome when you think about a total care patient and how that can affect families, especially if they lack a support system. So let's talk about some of the drugs that we use in multiple sclerosis. So these again are going to be non-specific anti-inflammatories. This is your corticosteroids again, and remember that's just decreasing some inflammation. We have some biological response modifiers. Again, those just reduce an immune response. And then we have monoclonal antibodies. They destroy lymphocytes that are involved in the process of multiple sclerosis and the disease process. And then there are some others that are just grouped in neurological drugs. So the neurologic drugs basically protect that myelin sheath, therefore giving some improvement in the transmission of those neurons and the firing. So we'll talk about all of those. So one of the first line of defenses for MS, or one of the first treatment options, is a non-specific anti-inflammatory drug, which is our corticosteroids. Now, if you don't remember everything about corticosteroids, go back and look at chapter 12 and some of your notes. But just remember some important things about corticosteroids in that it can increase their blood sugar, and we need to teach them to check it more often, and it also increases their risk for infection. So those two things are important when we're talking about corticosteroids. So we've talked about corticosteroids so much. I feel like you guys are pretty comfortable with them now, but those are two important things that we need to be mindful of. So if you have questions about corticosteroids, again, look back at chapter 12 or send me an email and we'll talk about it a little bit more in detail. But those are one classifications that can be used for MS. Biological response modifiers are given for MS, and the way this works in the body is they're given to reduce that patient's immune response to triggers that cause inflammation and that immune response. And there's a couple of different methods to deliver this particular medication. So you have beta interferons, fingolimod, glatramine, glatramine, and then the teriflunomide. Yeah, that's a mouthful. Just know that they're biological response modifiers, okay? Um, and remember, with MS and these medications, any medication that is given is always given by a specialist. So side effects or expected side effects for biological response modifiers are flu-like symptoms. So we're going to take temperatures and check vital signs. Headache, pain at the injection site, or some type of reaction localized. Peripheral neuropathy, that's just kind of that tingling numbness in your hands and feet. Elevated liver enzymes and slowed heart rate can be some of the side effects of this particular group of medications. Now remember, these patients are in a facility being monitored by a specialist, okay? So just just know that these are used to reduce the immune response in patients, okay? So monoclonal antibodies are given to slow that progression. They're inactivating lymphocytes that destroy that myelin sheath that protects those neurons. Okay, so all of these are given IV. They're either scheduled monthly, every 6 weeks, or maybe once a year. So this is going to be your drugs that end in AB. Okay, this is going to be, I'm not even going to attempt to say the names. So if you want to look at the names, they're on page 180. I'm in the middle of the page. Just know that monoclonal antibodies are given in specialized centers. They're given on a certain schedule. And one of the biggest side effects or risks with monoclonal antibodies is the fact that this is one of the higher risk categories for severe allergic reactions. So with that being said, if you know going in and you're the nurse in that center, that specialized center, that this particular medication can cause some extreme severe allergic reactions, what is one of the things that you want to have right at the bedside? Me personally, I want my crash cart and I want some oxygen and maybe some epi. Okay, I want my EpiPen close by. So just think of those types of things. Don't worry so much about the names of these drugs because I don't think any of them are actually on the test as far as specific names. They're just listed as monoclonal antibodies, okay? Again, our lymphocytes are being reduced, so remember lymphocytes are going to entail that lowered white blood cell count, so we're at a higher risk for infection. Okay, so if you want to review some of the others, increased risk, as I said, for severe allergic reactions, flu-like symptoms could be the side effects, some back pain, hypotension, edema, and your patient should never be taking more than one monoclonal antibody medication at any given time. Okay, so don't double dose them. One neurologic drug for MS is dalfampridine. Okay, dalfampridine is the one neurologic drug used. So this medication is going to protect those nerves in that myelin sheath from destruction, therefore improving those impulse transmission. Now, the side effects are on page 180 again, and there's quite a few, but one of the most important adverse effects of this particular medication is that it can cause a decreased seizure threshold. Now, we just talked about all of that with seizure activity. So remember, anytime you decrease that seizure threshold, you're going to increase that possibility of seizure activity. So with this one, you have an increased risk for infection, headache, dizziness, GI issues, constipation, nausea, flushing, itching, rashes, all of that. But the one extremely important one is that it can cause confusion and seizure activity. And as I said, the way it does that is by lowering that threshold, that seizure threshold. So as long as we keep that threshold lowered, you're going to see your patient with an increase in seizure activity most likely. So that is the last drug in this particular unit. So if you will have any questions about any of it all whatsoever, please send an email to let me know.